Magnesium sulfate, vitamins and electrolytes, Pharmacology Udemy Nclex question and quick tips. A 45-year-old patient presents to the ED after 2 syncopal episodes with palpitations. History: alcohol use disorder, 1 week of vomiting, diarrhea, taking omeprazole for reflux and recently completed azithromycin for bronchitis, use is ondansetron. Vitals: BP 9258, HR 138 irregular, RR20, SpO₂ 96%. ECG shows polymorphic VT with prolonged QTc that self-terminates twice. Labs: now 137 milliequivalent L, K 2.8 milliequivalent L, Mg 1 mg DL, Ca 7.4 mg DL, creatinine 0.8 mg DL, glucose 88 mg DL. ABG unremarkable, a pregnancy test negative. CXR normal. Which interventions are appropriate now to stabilize rhythm and correct the underlying problem? Select all that apply. A. Initiate 4 magnesium sulfate 2G diluted and infuse over 10-15 minutes, place on continuous telemetry. B. Give furosemide 40 mg for push to enhance magnesium excretion and shorten QTc. C. Begin potassium repletion to a target greater than or equal to 4.0 milliequivalent L per protocol while monitoring the rhythm. D. Institute seizure fall precautions. Assess deep tendon reflexes Q1, 2 hours. Hold slow magnesium if RR less than 12 minutes or urine output less than 30 milliliters HR. Keep airway equipment available. E. Keep calcium gluconate at bedside and be prepared to administer if signs of magnesium toxicity occur. F. Administer dextrose 50% before thiamine to correct possible vitamin depletion in alcohol use disorder. Correct answers: A, C, D, E. A. First line for Torsades de Pointes, even if serum Mg is normal, but here it's severely low. A 2G for bolus over 5-20 minutes is standard, may repeat once for persistent TDP. Continuous cardiac monitoring is mandatory to watch for rhythm response and bradyarrhythmias. C. Hypokalemia maintains QT prolongation and predisposes to TDP. Mg replacement alone may not correct arrhythmia unless K is corrected concurrently. Typical peripheral repletion is 10 milliequivalent kcl per hour, faster via central line if needed and ordered. D. Magnesium sulfate depresses CNS neuromuscular transmission. Early toxicity signs: diminished absent DTRs, flushing, lethargy, progressing to respiratory depression and cardiac conduction blocks. E. Calcium gluconate is the antidote for symptomatic hypermagnesemia. Having it ready is a best practice whenever Mg is infused rapidly or in high doses.